It's been a long day. I'm feeling really tired. Maybe I'm just coming down with something.
Imagine you awaken suddenly and you can't move. Your vision is blurry. You just don't feel right. Something is very wrong, but you can't call out for help because you can't speak. You're trying to yell, "Help! Help!" but no sound is coming out of your mouth. You can hear noise in the background. Most of it doesn't make any sense. All the words are jumbled together until you hear someone yell,
Get him to the ER now.
Mr. Smith has had a stroke. You hear the paramedics say,
Sir, can you hear me? You had a stroke.
"What? A stroke?" Instantly, panic sets in. Your mind is racing, wondering, what the heck happened? What is a stroke anyway? What happens now? What seems like days, but really only minutes later, a barrage of nurses and doctors are hovering around you. There are people everywhere, poking and prodding, strapping a machine to one arm and taking blood from the other. Now imagine this terrifying situation happening to you. Luckily, you're safe. But it did happen to Mr. Smith, and now it's up to us to help get this patient back to good health. So, what is a stroke, and what happens to someone during a stroke? Stroke is also known as a cerebrovascular accident, or CVA. Mr. Smith experienced what's called an acute left hemispheric stroke, when there's a lack of oxygen to the brain due to a blockage or rupture in an artery, resulting in the death of brain cells. Your brain is divided into two hemispheres, the right side and the left side. The right side of the brain controls the left side of your body, and the left side of your brain controls the right side of your body. Some functions may be controlled by both sides. As you can see, the left hemisphere is in control of functions like number skills, spoken and written language, and reasoning, whereas the right hemisphere deals with music, artistic functions, and creativity. Mr. Smith's left hemispheric stroke has caused right hemiparesis, affecting the right side of his body. The muscles on the right side are weakened, and they're impacting his limbs and facial muscles, which is causing nutrition complications related to dysphagia, which we will discuss later in this webinar. It is estimated that stroke is the second leading cause of death in the world. There are 3 types of strokes: TIA, or transient ischemic attack, which is a temporary blockage of blood flow. It does not cause permanent damage, but if untreated, it could cause major future stroke. Another is an ischemic stroke, which causes occlusions in the brain. They're more common at about 87% of all strokes, with main risk factors for it being smoking and hypercholesterolemia. This is when there are blockages in blood vessels that prevent blood supply from arriving to the brain. And lastly, a hemorrhagic stroke, at about 13% of all strokes. They're more likely to be caused by hypertension, and when this happens, a weakened blood vessel will rupture and bleed into the surrounding brain. The blood accumulated compresses the brain tissue. The risk of stroke varies by age, sex, race, and even where we live. The risk of stroke doubles for each decade between the ages of 55 and 85. Between the ages of 55 to 75, the annual incidence and short-term risk of stroke are higher in some men than in women. Several conditions can render blood vessels in the brain prone to rupture and bleeding. Hypertension, diabetes, and elevated lipids, as well as lifestyle factors such as smoking, physical inactivity, and a poor diet are all risk factors for stroke. Because some brain cells die during a stroke, it is possible that a person's ability to talk and/or eat after the event can be severely impacted. What are the signs of a stroke? Let's hear from an expert.
When someone is having a stroke, every minute counts. Just as putting out a fire quickly can stop it from spreading, treating a stroke quickly can reduce damage to the brain. If you learn how to recognize the telltale signs of a stroke, you can act quickly and save a life, maybe even your own. For both men and women, look for these 5 signs of a stroke, all of which come on suddenly. 1. Numbness or weakness in the face, arm, or leg, especially when felt on just one side of the body. 2. Confusion, including trouble speaking or understanding speech. 3. Trouble seeing, from one or both eyes. 4. Trouble walking, or problems with balance or dizziness. 5. Headache, especially a severe one that comes on suddenly. The clock begins ticking as soon as you spot the signs of a stroke, because some treatments can only be used if the patient reaches the hospital in the first 3 hours after symptoms appear. So don't wait. Call 911 right away and get the person to a hospital immediately, even if the symptoms go away. If you think someone is having a stroke, remember the word FAST. F is for face. Ask the person to smile and check whether one side of their face is drooping. A is for arms. Have the person raise both arms and see if one arm drifts downwards. S is for speech. Ask the person to repeat a short phrase and notice if their words sound slurred. And finally, T is for time. If you spot any of these signs, call 911 right away to get the person to a hospital fast. Strokes are medical emergencies. The sooner a patient gets treatment, the better their chance of a good recovery.
A stroke is a major life event that affects each person differently. You may find that you aren't able to find the right words or create full sentences. Maybe you'll experience slurred speech. Often, strokes leave you with one side of your body paralyzed or weakened, causing challenges with balance and the use of your muscles, arms, and legs. Swallowing difficulties are also common, putting you at risk of choking or aspirating your food and drink. Your brain might have difficulty communicating with the rest of your body, and some medications can cause problems with the functionality of your digestive system, bladder, and bowels. Dysphagia is a key nutrition complication in post-stroke patients. It causes an impairment of your ability to chew, swallow, and digest a regular diet, or even your own saliva. In 40 to 69% of patients, anywhere from 8 to 34% are at risk of malnutrition. Dysphagia not only imposes difficulty when swallowing, but can also cause pain, making enteral nutrition a possible intervention. Let's watch a short clip of a dysphagic swallow. Signs and symptoms of dysphagia include coughing and or choking when attempting to eat or drink, experiencing regurgitation of food or drink into the mouth or through the nose, feeling like food is stuck in your throat, or drooling. Dysphagia is a key nutrition complication risk in post-stroke patients. Risks associated with dysphagia include aspiration pneumonia, coughing and or choking, malnutrition, and dehydration. Malnutrition can delay the process of healing post-stroke and cause further complications and decline in function. Post-stroke patients have an increased risk of malnutrition. Therefore, it's imperative that we focus on preventing malnutrition in patients that recently experienced a stroke. Malnutrition not only prevents patients from reaping the benefits of essential macro and micronutrients in support of proper healing and rehabilitation, it also presents negative implications of outcomes such as morbidity, mortality, and increased overall healthcare costs. Working in an interdisciplinary team with access to a registered dietitian is important when considering the patient's new challenges when trying to do something as simple as eating. The dietitian will work with the team to first modify the patient's diet so that the texture and consistency is both palatable and safe for the patient to eat, before moving to an enteral nutrition approach. Enteral nutrition support is used to treat and manage the high risk of malnutrition after stroke. In hospitals, patients can deteriorate quickly after experiencing a stroke, and it is associated with fatality and poor functional status, which inhibits their ability to recover faster. A speech-language pathologist can further assist the patient by assessing their ability to swallow, helping them to learn new ways to swallow safely and suggest ways to manage drooling, so that they can safely transition back to taking food by mouth, most likely through a modified textured diet. Unfortunately for Mr. Smith, due to his problems with delayed swallowing and pooling saliva, the speech-language pathologist has determined that taking food by mouth is unsafe for him. An NG tube was placed due to his dysphagia, but the NG tube caused increased agitation, so he was put on enteral nutrition. When a patient finally passes the swallowing test, what are the steps to consider when transitioning a patient from enteral feeding to oral feed? You could establish safe feeding regimens with a dietitian and speech-language pathologist to provide necessary diet modifications. Transition continuous enteral nutrition to an intermittent schedule when appropriate. Coordinate oral feeding when enteral nutrition is turned off to stimulate appetite. Establish consistent meal routines. Document food consumption at regular meals and snacks. Monitor and adjust swallowing, nutrition, and hydration status. And you could obtain weights weekly to check for caloric intake and weight goals. After 5 days in the ICU, the speech-language pathologist came back to visit Mr. Smith. He reassessed him using a bedside swallow evaluation. It was determined that Mr. Smith could be transitioned back to Pyros. However, he needed to be on a pureed diet.
This food is terrible.
Mr. Smith is miserable on this new diet order of pureed foods and thickened fluids. Mr. Smith has been saving up for years and looking forward to a cruise around the world that he booked months ago to celebrate his retirement. Will he be able to go? Will he need extra help? Are there special considerations that Mr. Smith needs to make? Will Mr. Smith ever be the same again? As his dietitian, How can you help to improve Mr. Smith's nutrition status? Some things to consider are: what are his energy requirements? Which enteral formula would you use? How much is needed? How would you transition Mr. Smith from enteral feed back to per-os intake? What would you take into consideration throughout the transition? How would you ensure Mr. Smith is meeting his energy requirements?
Now it's time to test your knowledge. Mr. Smith's client history shows that he smokes half a pack of cigarettes per day, drinks alcohol socially, and he is retired and lives alone. What kind of risk factors did he already have for stroke? The answer: smoking and drinking. Smoking and exposure to secondhand smoke can increase the risk of stroke. Smoking increases atherosclerosis and aneurysm formation. It promotes blood clotting factors. In addition, heavy drinking can cause high blood pressure. Perhaps the living alone can affect Mr. Smith's food preparation and attribute to his physical inactivity. Question 2. There are 3 types of strokes: TIA, which stands for transient ischemic attack, ischemic strokes, and hemorrhagic strokes. What type of stroke did Mr. Smith have? The answer is ischemic stroke, described as his acute left hemispheric stroke. Question 3. What is nasogastric tube enteral feeding? The answer is: a nasogastric tube is a tube that passes through your nose to the nasopharynx and esophagus into the stomach. It is used to place nutrients down into the stomach when the patient cannot swallow. It would be inserted for patients within 24 hours when a patient has failed a swallow test and is not able to tolerate oral foods and fluids.
As you've learned throughout this webinar, there are many nutritional implications following a stroke. The road to recovery from post-stroke is long, and sometimes patients never fully return to normal. This is a very stressful and emotional time in a patient's life, which is why empathy and compassion should be at the heart of the provision of patient-centered care. We hope you've enjoyed this webinar. Thanks for watching.